Thank you. Welcome back to the Vermont House Appropriations Committee. It is Tuesday, I was going to say February 7th, 2023, 10 o'clock. We are going to hear from Dr. Levine on the budget from the Vermont Department of Health. So, sir, I don't think you've met everybody in this committee. Can't remember if you were in. Almost.
We can, the names, we can go around.
We'll go around just to be sure, and then when we end, then you can introduce yourself for the record and then start us off. I think we all have a nice handout. If you're watching, you can find materials on our appropriations webpage under today's date to find all of what we're looking at. So I'll start off. I'm Representative Diane Lanford. I live in Virgins and I represent Addison 3.
I'm Robin Shy from Middlebury.
I'm Pat Brennan from Colchester.
Tiff Lumley from Burlington.
Carrie Dolan from Waitsfield, and I represent Duxbury, Facein, Moortown, Waitsfield, and Warren.
Lynn Dickinson, I represent St. Albans County.
Mark Mahaly from Dallas. I represent Plainfield, Marshfield.
Trevor Swirl, Underhill and Jericho.
Woody Page from Newport.
Rebecca Holcomb, Norwich, Sharon, Stratford, and Thetford.
Jim Harrison, Chittenden, Bendon, Ellington, and Pittsburgh.
And I'm Mark Levine, Commissioner of Health. I'm accompanied by Anna Swenson, our Financial Director at the Vermont Department of Health. We thought what we would do this morning is just a brief introductory part to our department, so you have that perspective as we go through the budget. And then we'll do a little bit of a tag team presenting the actual line items on the budget. That works for everybody.
Please go right ahead.
Super. So, because we do have the coolest mission statement in state government, we always put that up first. Protecting and promoting the best health for all Vermonters. You can also see our vision and some of our values expressed on that slide. But to bring it into focus, the definition of public health traditionally has been sort of fighting infectious diseases and epidemics. You may know something about them. Preventing environmental health catastrophes, because indeed we have, as a collective planet, trashed our planet. And thirdly, preventing chronic disease. So promoting good health, keeping people from the chronic diseases that really occupy the biggest proportion of healthcare budgets. The more modern definition continues to incorporate all of those, but incorporates also developing strong intersectoral partnerships, because health can't do it alone. We need to essentially do all of our work across every sector in state government, every sector in society to really be successful. A little bit of the breadth of that is evident on the third slide here. It's focused more on communities and kids, but that's fine. So you'll see some of those themes that I mentioned as you go around the circle of this slide, but you'll also see things that are important to keeping people healthy, like doing adequate screening, preventing them from abusing substances, from nicotine on up, making sure that the environment, as I said, is quite safe, going from infectious diseases to preventing those diseases by immunization campaigns, et cetera. So there's a whole host of activities, and you'll see a little more of that as I go through the different divisions of our department. When we look at what our job is all about, which is keeping people healthy, we look at what are the factors that determine if people can be healthy. Most people think that adequate health care is the answer. But if you look at this pie diagram, you'll see that only 10% health care determining health. the things that determine health, when you ignore genetics, which we're kind of all programmed in with from the start, are really how do we practice healthy lifestyle behaviors, whether that be nutrition, activity, substance use, etc. And what are the socioeconomic and environmental influences that surround us? Those are really the major determinants of health. When we look at what can we do about those things, this is the so-called healthcare pyramid, where things at the top have the smallest impact and things at the bottom the largest. As a practicing physician for decades, I was really mostly preoccupied with the top 3 tiers of this pyramid. Did a lot of counseling and education, and indeed, those are always necessary but never sufficient, and they succeed. But counseling for someone to perhaps quit smoking might not be an overnight exercise. It might be counseling for a decade. Clinical interventions are those chronic diseases that I managed all the time: heart disease, blood pressure, diabetes, you name it. And then the long-lasting protective interventions are what goes in what we call the health maintenance part of practice. So making sure people have gotten their immunizations, making sure that age-appropriate screening tests have been done for cardiovascular disease, cancer, the big-ticket items, et cetera. But now in public health, and increasingly in healthcare, we need to focus on the bottom parts of this pyramid. So changing the context means making the individual's default decision the healthy one. So if you want to have good teeth and you live in a community that has chosen to fluoridate your water, well, you don't have to worry about too much beyond brushing your teeth beyond that. But if your community doesn't do that, we need to think of other strategies to help your kids make sure that their teeth stay healthy. If you want to go into a restaurant and not die of lung cancer, you need policies like secondhand smoke avoidance that we've already done here in Vermont, which work quite well. If you want to have people suffer less from the ravages of tobacco use, because that is the #1 cause of most bad outcomes in our country and disease expense, turns out you can do things like legislate, increase taxes, which have had profound effects. We did that trifecta a few years ago on vaping, increasing the tax to equal what combustible cigarettes would use, making sure the internet was a free environment, an environment free from allowing young people to access electronic vaping devices on it, and raising the age to 21. So those kinds of things are what's changing the context. And then the bottom one is the really heaviest lift, but it's the so-called social determinants of health, which are illustrated on this slide. And they're all the things that I think most legislators are pretty acquainted with nowadays. Whether it's access to wealth versus poverty, whether it's access to housing, whether it's stability in transportation, whether it's security in obtaining the right food and the amount of food you need to survive on. Those are the social determinants of health, which really determines so much more.
Representative Holcomb?
So just to clarify, if I'm reading this pyramid correctly,
Yes.
you're saying the most powerful things we could do as a legislative body to impact positive health outcomes or invest in things like housing,
Absolutely.
quality education, and reducing inequality.
When housing equals healthcare, we've succeeded in our message.
Representative Dolan?
Thank you, and thank you for coming today and helping us understand how when you move upstream, you help identify some of the more chronic and even acute conditions across our society. That's the sort of the take home I'm getting.
Yes.
But when you look at the prior slide where it shows behavioral patterns at 40%, environmental exposure at 5%, I think that doesn't really give you the whole picture of what the true societal contributing factors are to health.
True, because it has that 30% genetics, 10% healthcare. If you just ignored those and made 100% for the others, they would have a much bigger proportion.
Thank you.
And you use the word upstream, so the most upstream you can get is going even beyond housing and food security and poverty to health equity. So formal definition of health equity really involves those words, having a fair and just opportunity to be healthy. So what we find in Vermont, we are the or one of the healthiest states in the country. However, if you look at the level of health that we have on any parameter, it will look really good in aggregate. But when you begin to dissect that down and look at what we might term marginalized populations, suddenly it becomes dramatically different. So if you happen to be in a population defined by race, gender orientation, disability status, socioeconomic status, you don't enjoy that same aggregate number that makes Vermont look great. You turn out to have disparities in that data, and those are called the inequities that exist that prevented you from being as healthy as everyone else. It's best illustrated on the next slide, looking at equality versus equity. This is sort of a triptych, but on the left side, we have everyone getting a support to see the athletic event, but that support isn't necessarily helping every person, as you can see. If we change the level of support, we can accommodate anyone and still get a wonderful view. And then on the right side, sometimes called liberation, if we eliminate the structural barrier, we don't have to worry about anything. That's the nirvana state. Equity is really, really critical, and it's really the foundation for our whole state health improvement plan at this point. We do a state health assessment and improvement plan every several years. You may have lost track of the last one because we had this little pandemic in the middle that interrupted things. But what we learned from our state health assessment, which has abundant stakeholders at the table with public health, is that there were 5 areas that we thought we should concentrate on the most: child development, chronic disease, substance use, mental health, and for the first time, oral health, without ignoring those so-called social determinants of health that interact in such profound ways.
I'm sorry, Commissioner, on the housing piece, I don't know how I read it this morning in an article that Vermont is the second worst state in the country for homelessness.
Really?
Yes. Yeah, per capita, and I was a little surprised at that.
Right. When you walk through our towns versus you walk through
California,
San Francisco, Seattle, yeah.
we're doing a good job of maybe keeping them a roof over their,
Yes.
which we've had this discussion last week with the BAA. But actual permanent housing is, so they're homeless and maybe in a shelter or someplace, but I was actually a little surprised at that.
Which is why you're seeing state government have such a focus on it.
Yes, yeah, and constituents have let us know, or Vermonters.
Yes, and there's a very effective advocacy for that, but it's appropriate, absolutely.
Thank you.
And then, the populations of focus are the ones I just described that suffer from inequities. Although, interestingly, we added rurality because we have some pretty good data that shows that the more rural you are in our rural state, you can actually show disparities above and beyond belonging to one of those populations. A good example of that has been people with metastatic breast cancer requiring chemotherapy, and outcomes determined by distance from a place where they can obtain that therapy. More rural, not having the same outcomes as people living in a more suburban/urban environment in Vermont. So that brings us to sort of the structure of the department, which is, I'm going to go through each of these very quickly, one slide please, just to give you an orientation to that. But notice everything is on the foundation of health equity. So starting with the environment, thank you legislators, because we had a wonderful and very successful lead in school drinking water piece of legislation that accomplished just tremendous amounts and protected a lot of kids' brains from the harm of lead. That program in environmental health is also concerned about climate change. This year, PCBs in our school construction, things like blue-green algae, et cetera. Very important focus of the health department. Maternal and child health is a real important structure. Traditionally, public health actually focuses much more on maternal and child health than on the opposite end of the age spectrum. As an internal medicine physician, I've tried to change that, not just locally, but nationally, because it's really unconscionable that you would ignore the entire spectrum of life, even though we have a special affinity for the very earliest part of life, because data shows if you don't start out on the right foot, you may never get there. And that can be profound impacts on you throughout early development years and your whole life course. So this is an appropriate focus for maternal and child health within a health department. That deals with new mothers, not just their children. As you'll hear in some of our proposals this morning, that has to do with things like universal home visiting programs, embedding family specialists in pediatrics offices to attend to those determinants of health we've talked about. The WIC program, adolescent health, very, very important division in our department. Women, infants, and children. It's a national program that provides nutritional support for those populations who are under a certain income. They are often eligible for the things you hear about from DCF in terms of SNAP benefits, things of that sort. But the WIC program itself attaches the health department and nutritionists to the mother, child, and family. Laboratory sciences and infectious disease you probably have heard enough of in the last several years with the COVID response, but just suffice it to say, that is but one infectious disease on a very large platform. And they cover the gamut of things that you may have had or heard about. We also have vaccinations embedded there, and we have an entire public health laboratory in Colchester, actually, which is dedicated towards not only testing for COVID and other infectious diseases, but does a variety of other public health laboratory testing.
Representative Holcomb?
Does that, oh, sorry, over here. I know that everything was disrupted by the pandemic, but are you having specific strategies to try to catch school children up on their vaccinations as well, the routine vaccinations?
So the most successful strategy is actually having them go to their pediatrician because that's their most trusted health resource. And we have a wonderful statistic in Vermont. In the first 6 months of life, 95% of all kids are in their pediatrician's office. As you get on with age, it's at 90+%, not quite as high as 95%. So most kids are actually interacting in that setting, as are their parents. So that's the way to catch them up the most. Having said that, though we lead the country in vaccination rate in that population, it's not an impressive number. And, you know, mothers have been very cautious. We thought they would be doing a fair amount of watchful waiting for a period of time, but that time has passed now, and we still don't have the highest proportion of kids who are all eligible now getting that vaccine.
Well, I was talking about also things like measles, mumps, and
Yes, but
other
so
colds.
the second thing is really the national and international, I'll use the word crisis in quotes, with vaccination rates in general, catching people up. So the fact that at least people are going to the pediatricians, they are going to be caught up. I'm not as worried about that here in Vermont. But, you know, you hear about diseases like polio all of a sudden again, and it's like, you got to make sure that you do this. I have to say there is a very vibrant anti-vaccine community out there, and they have been mobilized by COVID response in ways we don't talk about, and become very, very front and center. And because there are many in our population who look at the internet in a very narrow way, they don't see the true information, and the misinformation is really just out there in abundance. Substance use programs gets a lot of press appropriately, and it's a big focus of our health department. But as they will be fond to tell you, it's not all opioids. Opioids are front and center because of the tragedy of the overdose deaths. Alcohol is still Vermont's particular problem and needs attention as we are giving it. There's also a big focus on stigma, because if you don't overcome stigma, there's a whole population of people with substance use disorders you'll never see because you haven't succeeded in that fundamental way. We have 12 district offices in local health that have WIC at each of them, have vaccination efforts. There really are boots on the ground across the state, so all of the policies in the central office and all of the great programs we want to go statewide with, that's really where it occurs because we have great people in those areas who have great connections and collaborations and partnerships with their local community resources. Health promotion and disease prevention as an internist is a fond area for me because I treated all these chronic diseases and preventing them requires a village. It doesn't require an office visit. So really having programs in place that allow people to age healthy can help everyone in the population. And that division also is very focused on oral health, not just all other aspects of physical and mental health. And you've heard a lot about emergency preparedness due to the pandemic response as well, but that also happens during Irene's and recent snowstorms, and also happens in an injury prevention mode, working on things like falls prevention in the elderly, suicide prevention with our colleagues in mental health, et cetera. And then lastly, but not leastly, we are a data-driven organization, and it requires a lot of important work on statistics and informatics to be able to credibly advocate for the policies we advocate for and the programs we advocate for, because they are coming from the data that we see. So that's your overview of sort of the department, and I was going to just do a couple slides on where our priorities are, and then we'll segue into the budget or questions, and then the budget.
Two questions, so Representative Shai and Representative Mahali, and then.
Sure.
Thank you. This is a great way to look at it. I hadn't seen that chart before, the pyramid, and that's a really helpful visual, so I appreciate that. With regard to emergency preparedness and suicide prevention, I'm wondering, specifically with suicide prevention, what you have seen in terms of trends, particularly through the pandemic through now. I'm imagining those numbers have gone up, but I'm wondering what you could tell us.
Yes, so the numbers in Vermont have never been one of those numbers we're proud of.
Right.
You know, so much in Vermont we're proud of. Suicide, we've been up there with the worst states. And we had one of the largest rates of increase over a 25-year period that ended in, I think, 2017. So we knew it was a problem still. The pandemic fed the fuel a little more, so it did get worse, though it didn't get worse at the same proportion, I don't think, as it was getting previously. But it did get worse, just like overdose deaths got worse, et cetera. So a lot of good things have happened in a very narrow period of time, so it's too soon to give outcome changes. But, you know, the 988 number went live. The whole CDC grant that we share with the Department of Mental Health has really caused a lot of programming to be unfolded at the level of prevention, both within the healthcare system and within communities, making it evident to people that everyone plays a role. And that it's not dangerous to ask somebody if they've been thinking about suicide, because it doesn't cause them to go out and do it. It's actually something that identifies a moment of intervention that you might not have had. There's also a new website called Facing Suicide Vermont, which you should all look at. It's just incredible. It tells people a lot of these things that I just mentioned, but it also has firsthand Vermonter stories So family members of people who succeeded, but also people who didn't succeed and their story. And now how they've come out of that and have a new life. There's a lot of resources on there as well.
Thank you.
And you had a question?
Representative Mahoney?
What do you think? I mean, I think going back to health statistics and informatics,
Sure.
incredibly important. So how do you feel about the state of things?
So when you look nationally, and like at the level of the CDC and in individual states, the two biggest problems are all infrastructure problems. Number one is workforce, because across all healthcare sectors, workforce has been really devastated since the pandemic, and public health suffered as much. And then the second area is data monetization. We are at a state where the CDC even is decades behind, not just years behind, decades behind in data monetization. Systems that talk to one another, systems that talk from the federal to the state, systems that actually look at the data in a way that is meaningful to us and that doesn't require sort of jerry-rigging to get something meaningful. So we all suffer from that. Fortunately, there have been some grants that have come out from the federal government to try to remedy that, but it's very early and it's inadequate at the current time. We'll take what we can get, but at the same time, we've got a long way to go.
Is our data modernization decades out of date as well?
Yeah, at least a decade.
Yeah.
Yeah. Doesn't mean we're not making do with
No, I
getting the
understand.
data
Yeah.
we need, but it's behind. And the workforce issues, we have hired a fair number of people in the last year on grants that address epidemiologists, laboratory support, emergency preparedness support, health equity. These are all big ticket items. All of these are what we call limited service positions in the lingo of budgeting. And they often expire in 2024, 2025. So they rely on a wiser Congress to say, hey, we gave you these positions because we recognize public health needed this to face the next tragedy or whatever we're up against next. And we need to renew these and more. Right now, we haven't heard that. We know the state of Congress, so it's unclear if their wisdom will continue or not.
Thank you.
Okay, so just briefly, what everybody knows as we came out of the pandemic, major issues, clearly a crisis in mental health, clearly a crisis in suicide, clearly a crisis in substance use. Often those are driven by what I call the biggest evil in our society, which is social isolation. And you would be alarmed at the rates of people who are socially isolated of all ages. And not only when we survey adults, but when we survey our youth and look at their rates of feeling not valued by their community, not really feeling stressed, feeling depressed, etc. And then, of course, education setbacks go right along with all of this. And then the concept of health debt. People's lifestyle behaviors and choices changed especially during the stay home, stay safe part of the pandemic, but often didn't revert back to their previous state. So chronic diseases are actually the reason why our hospitals every day of the week are so busy right now. It's not COVID patients. COVID patients make up 4% of their beds. And even those 4% often aren't there for COVID. They just tested positive. They were there for another reason. So hospitals are filled with people who had exacerbations of their chronic diseases, production of their chronic disease because of their lifestyle changes, and fear of connecting with the healthcare system during the pandemic, which delayed their care. So all of those are big ticket. We can't solve all those in a few months after the pandemic.
What is it nationally? We've lost 2 years on our lifespan or something?
Oh, yeah, life expectancy went down yet again, yeah.
In a lot as well.
I don't know if we can have that data. I don't know. But certainly like national. So themes you'll observe in our budget, besides the ones that we just showed, I'm always focused on protecting kids' brains, whether it be from lead, whether it be from nicotine, whether it be from other substances. We have the Substance Misuse Prevention Council, which continues on, and we have a whole program of recovery and revitalization from COVID, which is really, really important. But the way this translates into kids right now is ACEs, adverse childhood experiences. We've had for a couple of years now a real focus on this multi-generational approach to focus on families and their youth. And one of the ways we've done that is through home visiting programs, especially of our most vulnerable populations, with nurse practitioners and family specialists, which is a very successful evidence-based program, which, as you can see by the slide, has an incredible return on investment. There's also a newer program called Dulce, which you'll hear about during our budget presentation, which is embedding a family specialist in every pediatrician's office. And we've piloted that in 5 locations and already seen that the evidence we knew about is happening here in Vermont as well, because it's an opportunity to identify those social determinants of health, which the physician themselves can do nothing about, but with having that specialist in the office can have referral to interventions, resources, legal collaborations, et cetera, which are very, very useful.
Can I ask you a question, sir?
Yeah, sure.
You and I actually have done some, I guess it was some radio, audition, right? On
Yeah.
After school together, that was.
That's all, that's,
So that's a part of this prevention and the ACEs piece, right?
that's a big part.
Right, that we both were, you would.
Very adolescent focused, as it should be,
Yeah.
because of the time in life when people start experimenting in maladaptive ways.
Time. But I was just wondering, and I wanted to thank you because the youth council is
It's up and going.
up and going. And that was something I was just wondering how their connection to some of the issues that you speak of on the social isolation and these other, how we're working with that voice.
Yeah, I think the after-school programs and summer programs are key in that area.
Right. And the youth council is it's just up and running. I think we met once or twice.
Right. And that's derived from, from way back, the Iceland project, which really, the take-home lesson from Iceland, besides having curfews, which we don't really need because they have a part of the year where it's daylight like till 4 a.m. and then they get like an hour of darkness. So their kids were out drinking during those hours. But the take-home message was the youth connection and making sure that the youth voice was heard. It wasn't just a bunch of adults saying, we got to figure out ways to, prevent.
Pleasure to meet them with some of the others was what spurred the whole youth council bill. I've got Representative Holcomb and then Representative Dolan.
So I have 2 questions related to that, and this is going to come up obviously in the context of the CDC budget. And the first is you have a very specific vision here, which I love. Do you talk to the other departments? Because this philosophy and theory of action is not consistent across AHS agencies. I'm just going to observe that and leave that on the table. And then the second question, to me, the other interesting part about Iceland, which is not true in Vermont, is that they were municipal programs. So they were socially integrated in a way that our delivery has not been. By choosing the delivery model we set up 2-tiered access with public school programs serving kids with disabilities and a disproportionate number of economically disadvantaged kids. And the rest of the resources really creating separate environments for people. Does that have a long-term impact on children's sense of integration with their community? And why was the decision to implement it that way instead of using the existing capability in, say, 21C? So we've made some decisions here, and it does impact the inclusiveness of the programs. And I'm just curious if you could comment on that.
So I'm going to be able to spend more time on your first part of your question than your second part. The second part does go way beyond the public health arena to so many other programs. However, one thing the pandemic did was bring us together across state government in a different way than it had before. So we refer to things like health on all policies, meaning we inform other policies that people may not have had the insight about to have a health lens applied to them, just like now we have a health equity lens applied to them. One of the things the secretary has done, and I've done for a number of years in AHS, is try to make the 6 departments talk to each other more and be more consistent. So for instance, with mental health and I co-chair a mental health integration council, which you'll get a full report on after the summer, which is to do just what it says, integrate. The suicide work is all joint between our 2 sections. The healthy aging work is all working with Dale. The maternal child health part of our department is very aligned with DCF in terms of these programs and how does home visiting, Dulce, and parent-child centers all interact together because they all have different sort of people leading them. So that's the sort of theme that we have and that I think is unfolding. So it's probably going to be the best it's looked ever, even if it doesn't look great to you yet, just because that is the ethic that we're sort of doing these things in and talking about. And AOE, everything we put out during the pandemic was sort of a joint memo from Secretary French and myself about why we were saying do this or do that within the schools to manage whatever they needed to manage at that juncture in the pandemic.
And then some of these are structural issues. I mean, the multi-generational approach we know works. And I know our parent-child centers do an amazing thing. Because there has been systematic underfunding, I would argue, and others may not agree, of the mental health system, for example. What we're seeing is a lot of that cost drop back into the education fund, which is explicitly barred in statute from supporting multi-generational approaches. So we're going to pay out of our left or our right pocket, but how we pay actually affects whether we can achieve evidence-based practice. And what I'm trying to say is that what I don't see is that vision being consistent across agencies. So I'm delighted to hear that that is trying to work on.
No, thank you. And I appreciate what you just said about where we have work to do.
Great. Representative Dolan?
Thank you. My question is a bit more elementary, but very concerned, and I see some overlap here between social isolation and societal impacts is on bullying.
Yes.
When you see how bullying either through after-school programs or social media or how it impacts the child is I think in ways that we are seeing continually play out in the worst ways and possible. And yet 10 years ago, it was a major focus. And I know we've had a lot of diversions with the pandemic, but curious to know if you could comment on how we, as something that overlaps into other departments as well, and agencies, how we can do better for our children with respect to addressing just that social interaction and bullying generally.
Right. So it all boils down to how we look at social media and our youth's involvement and engagement in social media. Because, whether it's bullying, whether it's what unfortunately happened with CVU, with a racist posting that was only up for 2 hours, but it basically made a whole bunch of schools say, we're not playing CVU. And the principal had to do very in-depth work with not only the individual, but the community and the school community and beyond. Whether it's the impact on youth, just not that they've been bullied, but just what they saw on social media that made them feel inadequate and become suicidal, even though the reality was what they saw wasn't reality. It's just the reality that was on social media. These are huge, huge problems. And they really fundamentally derive from how do we connect with one another. So efforts to improve connectivity among people, which doesn't mean what we're doing, with Zoom and this meeting, but that's a functional way to get this accomplished. But when it comes to actually people in society, connecting them is the key to success. And whether it's a youth who's in high school and just feels isolated, or whether it's a 75-year-old who lives in a very rural part of the state and still has the firearms from when they were in the war, we have to deal with all of those extremes because that's the reality of where things are happening. I don't have the answer for you, but it's all about connectivity programs that do that. So that's why I say public health has to have abundant partnerships and collaborations, because the groups we do partner with address these issues. We can't address them with a staff of 600 people and, across Vermont, but they can.
Representative Dickinson?
Yeah, this sort of follows on the same question about the bullying issue, the social media, whole behavioral interaction. I mean, one of the things that I don't think I don't know if you do anything with it or if it's something, but there's a quality of grit that apparently is an indicator of success in young people. And how do we take that, the negative things, and turn it into something positive?
Right. So that's all the work that
Quality of what?
Grit.
Great.
So that's all the work that goes on with what's called resilience. And actually, most of the focus, not just in a mental health setting, but even amongst employees of the state of Vermont, amongst children in a classroom, is on ways to improve resilience building. So that's a protective factor, but you know the risk factors, and sometimes the risk factors are really hard to deal with. But the protective factors, if they don't exist, we can introduce them. And that's really a big focus.
Yes. Representative Blumenauer.
Thank you. One of the things that I'm concerned about, you just mentioned all the community organizations with whom you need to partner in order to deliver the kinds of services that lead to connectivity, resilience, et cetera. And what I'm hearing is that those organizations are really hard pressed to provide those services. And I'm just wondering what your impression is, what your take on the kind of the health of that kind of social, emotional safety net is in our state.
Yeah. It's the same issue as we were talking about with workforce. It's across every sector. So whether it's within the government, whether it's in education, whether it's in the healthcare setting, whether it's in the public health setting, whether it's in the broader partnerships and collaborations who try to deliver on this, it's everywhere. So in that sense, the health is not good. There's great enthusiasm, motivation, desire, commitment, but one can only do what they can do with the bodies they have. So there is a threat to that. There's no question. It's not something necessarily that throwing money at helps. And that's one of the areas is so poorly funded in terms of what they can pay their salaries that it could help.
Well, and I think that goes to kind of my point, because I think that, it's part of the challenge is that a lot of these organizations have been level funded or they receive almost no public support at all. For the organization that I ran that offered job training went from being, almost all publicly funded to public funding being about 5% because of cuts that were made, changes in federal legislation that made it almost impossible to get people through all the evaluation they needed to. And so I think the workforce is an issue, but that is a symptom in part of an eroding kind of foundation.
Whole infrastructure.
Yeah.
No, it's just like in public health, our workforce issues began 2 to 3 decades ago, and they were continually eroded by federal legislation.
Yep.
Further, now people have recognized that, well, you can't have a rebound overnight and everything changes. And the same thing for some of the supports of the organization. So we will see that come around, that pendulum will swing again, but it won't be as timely as we want it to be.
You good?
Well, I'll just do these last couple and then we'll get right to our budget. So obviously, a lot on opioid crisis is appropriate to remain a huge priority. There's so much tragedy wrapped up in that. And I mentioned the environmental health. We're specifically focusing on PCBs in schools now, but also a lot on climate change and climate and health. You'll hear less of the health department and front and center there, but we're sort of the data drivers behind that and bringing the problems to the table that we want things like gas emission to solve, if you will. So.
Representative Page?
Yes, just going back to the previous slide, you mentioned protecting children's brains earlier, removing lead in drinking water in school. And because Vermont has a much older housing stock, I wonder if that's an issue in some of the older homes and whether that should be included in the slide as well.
Well, so the reason it isn't is because it's old fashioned. We've had a lead program for so long that addresses the paint in older construction homes, so that's sort of a given now. The lead in the drinking water is the new kid on the block. The lead in the paint and the lead in the old homes is something we've addressed forever. So when you look at the kids whose blood level of lead has been too high and requires intervention, that's usually the reason. And those families are very connected with our programs. There can be more done. I don't want to just say we checked off the box, but we pay attention to that.
Thank you.
Representative Dolan, and then I've got a question.
I am aware, though, that old housing stock have lead solder, and so there can be lead in the drinking water as well. With the new EPA lead and copper rule, and the state really using right now federal funding to help in replacing those lines. There are lines to housing developments or homes. That's a priority.
I agree.
So is there a standard that children are tested for lead? I mean, that there's a standard that you measure, but I'm thinking if you go to your pediatrician once a year, if you're 6 years old or 10,
So,
are they testing everybody now saying, oh, this is.
Yeah, at 1 year and 2 year.
What, 1 year and at 2 year they're testing?
So that's a capillary, like a field stick in the office. And then if you need blood tests to support that further, you get that. Not 100% of kids are getting it, I can be quite honest. We're in the 80% range, but at the same time, that's pretty good. But it's really a performance improvement issue for the healthcare sector. But that's our.
It'd be hard to tell if an 11-year-old at that point has been exposed. That was what I was thinking.
Yeah, the 11-year-old would be identified through behavioral problems or learning disability problems.
But it's not a part of the standard, go for your well check every year.
No,
Let's run.
no,
Yes.
specifically focused on those very earliest times of life.
The earliest, but,
And that's where the brain can be saved.
right.
So that's the key.
But we,
People who, like, if you started suddenly unknowns to yourself getting water that had, like Flint, Michigan, you wouldn't change overnight. And we'd say, we better do a lead test on you. But there would be an impact.
Right.
It would take time to show that. Whereas a kid with a developing brain, that would be very quick.
my children are too old, but I would be like, can we just test it? Go ahead.
You're not saying we're beyond hope, are you?
No.
With our aged brains? Clear that up.
So I'll introduce the budgetary part of this, which is really another pie chart, just to impress you that most of what we get is federal at the health department level, but there is this light blue chunk called the general fund, but you may be used to seeing general fund be a much higher proportion of the department's budget. Not true for us. It's really federal and sort of global commitment money. Just to give you that perspective.
And the special fund,
And special funds.
Variety of them, or?
We do have a variety of them. And the total budget is closing in on $217 million. We have 3 appropriations, which are administrative, public health, and substance use. The overall increase in our budget is 5%, and this budget provides full funding for the department's current service budget.
Representative Harrison?
Last year, through the, one of the opioid settlements, I believe we set up a special fund for.
Save the question.
Okay.
For the end, because it comes.
Okay.
You'll hear more. I'm now going to turn over some of the line item crosswalk to Anna Swenson, who I introduced earlier.
Thank you for putting the B number on the B311. That's talking our language now, yeah.
I cannot take full responsibility for having done that. Someone far more brilliant than I.
Okay, so happy to walk the committee through the budget. So the first appropriation is administration and support. So this slide that we're looking at currently, slide 27, this shows the full ups and downs. So every single line item in our budget proposal, you'll see there are some numbers off to the left-hand side, and those numbers correspond to the detailed descriptions that you'll see on the next few slides. So in administration and support, starting in personal services, and you will see a number of these line items recur across all 3 appropriations. So we have more detailed descriptions for those in the administration and support, and then we've just summarized them in the other appropriations. So first up is the increase in salary fringe. And so this is 4 positions in the admin and support appropriation, the change in salary fringe costs over 23. This excludes the impact of changes in the retirement rate. You'll see that as a separate line item further down. Second line item here is a technical adjustment, position fund splits to earnings. So essentially what we've done here is we've updated the fund split for positions that are funded by departmental administration to bring those costs in line with historical actuals and what we expect to actually see in 24. That third line is the adjustment to vacancy savings. So again, just updating vacancy savings to be in line with what is expected going forward.
Do you have an idea of what your rate is? Is it 4%, 8%?
It's about 10%.
10%.
And moving on to the next slide, some additional line items in personal services, the retirement.
A question.
Oh,
yeah, go ahead.
Don't mean to interrupt, I'm sorry. When you talk about that adjustment to vacancy savings, but in the, maybe I'm reading this wrong. It's an adjustment to vacancy savings is a minus 136,000. Oh, I see, and then you have the global career. Okay, just catching up.
Oh, sure. No problem.
But regarding that vacancy savings, can you describe that a little bit more? Are you holding positions and not filling them?
No.
Or is it just
It's
part
just a normal churn of turnover. Yep.
Thank you.
Sure. So line 4 is the retirement increase. Line 5 is salary fringe for 2 new positions in this appropriation. And these are 2 positions that are fully federally funded and they are limited service positions.
But you just said 4 positions under salary.
It's 2.
Oh, it's 2.
Yeah, 2 in admin and support. Line 6 is the FY24 estimated impact of position class action reclassification requests. So we had a number of positions that were put in for class reclassification. One of those positions is in the admin and support appropriation. So this line item reflects that. Line 7 is an internal service fund charge. This one is workers' compensation, and this reflects a slightly decreased cost over 23, and this amount was provided by finance. Next, moving to operating expenses, the first line, it's actually a 5-line item, so we've kind of lumped together all internal service fund charges, changes to those. The net increase is about $250,000 across all 5 lines, and the individual line items are detailed there. ADS, human resources charges, insurances, et cetera.
Representative Shine?
Thanks. If I look over to the total, about half of that is vision. And that's the budgeting?
Vision is the financial system.
Yeah, how come it's so much? Is it that way I haven't really looked at the other
Usually roll them all
departments.
up.
Yeah, so I don't know if this is sort of standard, did the rates go up? Is this a lot more for you than it is for other departments?
Yeah, these amounts were provided by finance, so we.
Okay, because it's coming from 5 different places, I see. And it's $109,000 for vision, that's just, right. I guess that sounds like a lot of money to me for that. Because you're not the only ones using it, so.
Right.
Let's take it out.
Or not, maybe it's more, I don't know.
Yeah, I guess I'll ask Adam.
Yeah, definitely.
Who has finance?
Yeah, I'm gonna ask Adam.
Ask Adam about the vision increase.
Okay. Maybe he's listening.
Answer it wasn't supposed to.
It's okay, we're not on the floor. Thank you.
Okay, sorry, go ahead.
No problem. So the second line item here in operating expenses is a net change to multiple expense account codes. So essentially you'll see that this line item nets to 0. So this line reflects a change in the funding mix for operating expenses based on actual historical costs and expected funding. And then the last line item in the admin and support appropriation is in the grants major object, a reduction of about $2.3 million. During the 2021 legislative session, the General Assembly appropriated one-time funding for a temporary expansion of programming for scholarships for medical and nursing students. The funding will not be available after 23. So this line item reduces that amount for 24.
That seems, I mean, it's complete. Is there something else, I mean, nursing scholarships and students, what else is there out there right now? I mean, when we looked at the BAA too, there's a lot of places that there's scholarships. And I want to make sure we're not going backwards. This isn't.
Sure, the department does have base funding for loan repayment and scholarship programs. This was a temporary expansion.
This was okay. So what's left that you have for this?
Left, I could circle back if you want me to total them now.
Yeah, we want to make sure that that's especially, for the nursing students.
Okay, yeah, so we'll follow up on the base.
AHAC?
AHAC.
Yep.
Yeah, our partners on that.
Oh, Representative Harrison.
Trying to help you with your peripheral vision.
Yeah, you're doing a great job.
Do we, I know we, as the chair said, we invested a lot and we had some of these federal funds to help address some of the critical needs in the medical field, especially nursing. Do we have any evidence that money actually helped? Or is it the fact that we still need people to actually fill those roles? I mean, we spent a lot of money and I hope that it had some positive impact, but I don't have anything to.
Yeah, it's also timing. Is it too early for you to find out if it actually helped? Because
this was 2020.
People at Impact still have to go through their years of training before they decide where they're going to actually get a job.
But do we have any like rolling numbers like we've got, potentially, 200 more people entering the field than say we did 5 years ago? I mean, I don't know what the.
No, you're justified in asking. Well, we can get that information.
Okay.
Yeah. Get that down.
We've just got a huge shortage and we're paying for it in other areas like traveling nurses.
Traveling nurses.
Yep, tens of millions of dollars. I have Representative Dolan, Representative Dickinson, Representative Mahaly.
That was my follow-up, just the cost of the traveling nurses. How do we build our own workforce to help offset that? It's always a timing issue, upfront costs initially, but the long-term benefit of that kind of, prevention of having to rely on traveling nurses.
Yeah, do you have AHEC in your budget? You do, okay. And that's the scholarships that they normally do, or the loan repayment that they do.
Physician loan.
Do they do ones for nurses? They do, okay. That's been around for education, that's the standard, okay. In terms of the scholarship, maybe not for the medical students, but certainly for the nurses, to address that issue, have you been working with the educational institutions? I mean, VSC had we had the critical profession scholarships. Is that related to this, or is that separate, or?
I don't know as much about the nurse program as the physician program.
Right.
We can get answers to you.
That would be amongst the college, maybe UVM, but that was a very aggressive workforce program that we did. It seemed like there were numbers they had. But the biggest impediment was getting nursing educators with master's degrees and could be, that's their barrier to more nursing.
The salaries for the educators was not adequate.
Yes.
I'm having trouble hearing you, I'm sorry.
Salaries for nurse educators was not adequate to keep that a robust.
There's a barrier. You don't have the educators that are qualified that can be accredited institutions. You can't accept as many nursing students. And part of it is a salary barrier.
Which is what we
Oh,
just.
for the teachers, for the preceptors.
Which is.
Well, for the
PAA.
nursing educators in the colleges.
Right. We put some money into
Into
that.
VA.
Yeah, we're still putting money into it, but it's not related to what you're doing.
No.
But it is related to Jim's question, because we
It's related to his.
don't know if we're subsidizing people who were already going to do nursing, or if we
It's a grow your own issue. You gotta grow your
Right.
current staff to make them more educated. You gotta go
Yeah, that's what we did as big.
tuition reimbursements. I know the hospitals are doing a lot of that stuff.
Thank you for letting us entertain ourselves here with this kind of.
It's helpful.
So, yeah, it is. It's very helpful. Representative, if you're done.
I'm done, thank you.
Okay, Representative Holly.
I guess I'm following on the same thing. Let's go back to this 2 million, 2.2 million. This was money, one-time money for scholarship. If you had it, could you spend it again?
I think we have
That's good.
to.
That's a good
It's a
question.
good question. We can follow up on that.
I mean,
That's why getting the balance
Because
is what
again,
we've got left.
it's hard to assess the outcomes because they haven't yet occurred.
we're looking for help and thinking
Yes.
through. I mean, here we are hearing, we heard it in BAA, we're gonna hear it again. We're pouring money into visiting nurses. And we'd like to do something, but assess the value of what we have done. As Representative Harrison has said,
Yeah.
and we looking for help. And I think maybe you could help us to some extent.
We'll get you that information.
Thank you, Vic.
I would look up AHAC is Area Health Education Centers.
We had to look it up to, all right. There's a nice, information about it, which is.
One
Okay,
last question on that. It comes out of the global commitment. What exactly does that mean?
it's a global commitment investment, so it's a federal-state partnership. And
And
part of
so
the
that's
Medicaid
ended.
program.
So that money's not there anymore, or it could be there in the future from global commitment.
The match for the global commitment was one time, so the state share of this money that we're removing from the budget for 24 was one-time money.
Thank you.
Thank you.
Okay, so that concludes the administration and support appropriation. So moving on to public health. So again, starting in personal services, we'll see a number of the same line items that we saw in admin and support, salary fringe, retirement, that sort of thing. In this appropriation, we have 26 new positions. Again, all of these are funded by federal grants and they are all limited service positions.
Where are you?
I am on slide 33.
You said they're all limited service?
Thank you.
It's line 5 on your.
Yeah, okay. Thank you.
Sure.
Thank you.
So next up in public health is operating expenses. So the first item here is increase for the opioid antagonist program. Naloxone is the medication that can reverse an overdose caused by an opioid, and the health department works with community-based organizations to distribute that life-saving drug. There has been a significant increase in demand for naloxone, so we are requesting an increase to meet that need.
I see that coming, which special fund is that coming?
So it's two special funds. So on the bottom of that slide, we have listed the proposed funding. First is a $400,000 increase in the special fund from the Evidence-Based Education and Advertising Fund. And then second is a $1.98 million appropriation from the Opioid Abatement Special Fund, which is the Opioid Settlement Fund.
Okay. Oh, sorry. Yep, please.
So lots of salary in here. Salary and fringe is almost $500,000 in general fund increase and 2 million total. This is before the 26 positions. And so how many people are we talking about in
The
that?
majority of our staff are in this appropriation. It's about 550.
500, that is helpful, thank you. I just scope. And then you have 26 new proposed positions. What are they? Or are you going to tell us?
They're all the ones that I described earlier. So epidemiology, laboratory, emergency preparedness. All part of the new federal funding we're getting.
Thank you.
Yep, because I see they're all in federal funds.
Right. That's a lot of people.
Yep, so,
And these are all being paid for by that new opioid settlement fund? No, it's not.
These are separate grants that involve workforce and health equity. And then your question on the opioid settlement, we have an opioid settlement advisory committee that meets regularly. We'll be meeting again next week with a full list of what the monies are being recommended for. But that committee reports to the health department, makes its recommendations. We then make our recommendations to the legislature. Legislature does what they want to do next. So one of the recommendations here is that a portion of the initial allotment of settlement funds go towards naloxone because of the expansion in need and demand for it.
You've lost me. So that's not part of your budget recommend right here?
It is.
It is.
It's the way we get to it.
Okay.
Process I was describing.
The 2.38 million, yeah.
Yes.
Right.
So part of that is the evidence-based education and advertising fund is a fee, if you will, that pharmaceutical manufacturers pay into that has supported this program for a number of years, as well as some other initiatives. The same manufacturers are now often having to do these litigations, settle, and pay huge amounts of money over years to states because of the opioid crisis. We anticipate millions and millions of dollars through that pathway, some of which we're advocating go to this cause.
You answered my question. Thank you. Thank you.
Okay, and then just a couple of routine line items in operating expenses in public health. Another internal service fund charge for fee for space, increased costs there over FY23. And then finally, as we saw in the admin and support appropriation, we have a net operating expense account code changes line that nets to zero. And that line just reflects changes in the funding mix for operating expense account codes.
very straightforward, well documented.
Piece here.
Did you have a question?
No, I was.
Okay.
No.
So then finally, in the public health appropriation, we have two line items related to grants. The department has two memorandums of understanding, MOUs, with other departments within the agency, DEVA and DMH. And so these line items provide the spending authority in the interdepartmental transfer fund for us to expend funds received under those MOUs.
And the top one is part of chronic disease management. So self-management programs for chronic disease.
And so that concludes public health. Our final appropriation is substance use programs. So
And
again,
this budget is Representative Blumen's, is 313, yeah.
So again, starting out with the same line items that we've seen twice before already, salary fringe increase, technical adjustment for fund splits, vacancy savings, retirement, and then new positions. There are 4 new positions in this appropriation, again, all federally funded, and again, all limited service.
At some point, it would be helpful to see all the new positions, you know, like on a list.
Yep.
That would be great. And that they're federally funded and where they're.
Yep, yeah, we can definitely do that.
Can I?
Sure. Oh, yep.
Maybe you're going to explain this. You're not done with this category, are you? This budget?
Just no.
Okay, I'll wait for you to tell me what you're going to say.
Yet to come.
Okay, so next up in the substance use programs appropriation, under the grants major object, this line item converts recovery center funding from GF to global commitment investment. You'll see this is a net zero line item. It's simply a change in funding mix for the grants to recovery centers. There's no change to the amount that will be awarded.
And there's still 12? And let me, I'm sorry to be so, but this the 540 represents level funding?
Right, so we're level funding the grants. It's just a change in how those grants are funded. Okay, next up,
Is there a question? Yeah.
Oh, yes, please.
When you say level funding the grants, who do those grants go to?
the recovery centers.
The 12 of them.
So when we level fund our recovery centers, and yet costs increase yearly after those recovery centers in being able to do the work when they have a level funding budget.
So from a financial perspective, I would just say that there was an increase in '23. So the '23 amount that was put out was actually $540,000 greater than it was in '22. So we're level funding from '23 to '24, but they did see an increase from '22 to '23.
Okay, but it's still probably just, it was adjusted back in '23 for, again, further increase in costs. Anyway, I've just flagged that as a concern.
It's almost an unanswerable question because it relies on knowing the impact of the increase and was that satisfactory enough or not. We'll see that play out.
Thank you.
Good.
Okay, next up in substance use programs, we have a realignment of the SFY '23 vote base appropriation, which is a general fund appropriation. This is overall reflects a change in the funding mix for substance use disorder treatment. We are budgeting about $1.6 million to stabilize the existing residential treatment providers, and that's going to be funded in part as Medicaid investment. And then about $954,000 for general fund for treatment expansion.
I asked.
Oh, please go ahead. Sorry, my head's like on this teeny tiny line.
If it's too basic, and I'll defer to all afterwards, but you have an increase in the substance, the residential treatment, and then you have no increase for the recovery or substance abuse recovery centers. I mean, isn't that the same group, or are we talking different populations?
So let's talk, there's a continuum of care. A person with substance use disorder entering the system, we have the well-known hub and spoke system,
Right.
which is really outpatient focused and intensity driven by more intense in the hubs, less intense at the spokes. If at that point in a person's course of illness, it's deemed essential they be in a more inpatient setting,
Okay.
a hospital, that would be a residential facility, of which we have 3 in Vermont. People stay generally in the range of 21 days at that facility. It kind of removes them from the environment they were in. But then they have to go to another environment. And whether you're in the hub and spoke or whether you just came out of a residential and now are in a hub or a spoke, you need to be engaged in your recovery. That's the role of the recovery centers. So trying to maintain people in a state of remission for their condition and return them to a productive life with supports in employment, supports in housing, supports in counseling, peer support, et cetera. So the focus on this is really on the fact that of all parts of the treatment system during the pandemic, the one that seemed to have the least resilience was the residential facilities. They had to be have their number of beds severely curtailed because of outbreaks and illness and staffing issues. They also, in addition to that, really just had difficulty maintaining the beds that they had with the available staff, even when they didn't have staff out sick because of COVID. So they just had a tremendous struggle, and they need further support. So what we've done is sort of rearrange the same pot of money to support a little more of their needs, leverage some general fund money now through Medicaid to give us an additional 27% through the Medicaid formula, and still focus on these other aspects of the treatment system, but not the recovery. That's sort of a separate bucket, if you will. This is really substance use disorder treatment focused. Hoping
Really clear.
So, I mean, treatment is treatment.
I think.
So basically, treatment
Continuum
is
of
medication for opioid use disorder, and it's counseling, et cetera, all of which continues as you're into recovery, but the recovery centers are very much focused on you as an entire holistic person and all of the needs you have, in addition to maintaining your sobriety from what substances you've had. Hope I'm being clear.
Yeah, no, you're fine. I'm just trying to understand why we increased one area. Obviously, you saw the need for increased costs.
It's really a crisis for the residential.
They have price pressures too. I'm not looking for increases where they're not needed, but
Yeah.
that does beg the question.
And they all had the same traveler issues that hospitals had too. So, I mean, they had substantial increase in cost and stresses of workforce.
Go ahead.
Thank you, Madam Chair. Can you tell me, of those residential treatment centers, are they running at full capacity now?
Right now, I can't tell you. I know that often they have waiting lists. But real question you're asking is, do they have the same number of beds they had pre-pandemic as opposed to their full capacity with a reduced number of beds and
You know what, I get,
increasing that?
I think what I'm really getting at is when this says expanding capacity, what does that mean?
So having them have the number of beds that they thought they had originally but couldn't maintain due to the pandemic.
All right,
And making it easy for a Vermonter who's identified to get into one.
so this isn't actually expanding the service or number of beds. It is enabling those treatment centers to run at capacity with the staff that they would need.
Right. Which may mean expanding beds, but not beyond what they originally started with, just back to where they started.
And I'm assuming just the line above, expansion of substance use disorder treatment. And that expansion looks like what?
Yeah, so
You mean the 954,000?
I'm in the crosswalk. It's, it's number 2.
So that's really, we have two types of beds in Vermont. We have the public inebriate program, which is a sort of a 24-hour stay kind of thing for people who might otherwise end up in a correctional facility but don't need to be there. And then we have what's called sobering beds, which are really people who may be in treatment, who may have relapsed and may be back to square one, but need to be supported in getting back on track again, and can stay days or even weeks in a different type of bed. So sobering beds, residential beds, those are all included in that aspect of the treatment, if you will. There's also, I think, a hope in there that there would be more capacity in residential facilities, which you were talking about earlier. But that's out of this bucket as opposed to the previous bucket, which is just getting the residential facilities back to operating the way they need to operate for what they have at the time.
Okay. Thanks. I can follow up later.
Yeah.
With more specific questions. Thanks.
Good. All right.
Yeah, that's one more.
Okay, so next up is an increase in general fund for substance misuse prevention. This is related to the cannabis excise tax revenue. This amount, the $1.41 million, reflects about 30% of the projected cannabis excise tax revenue for state fiscal year 23. And during the 2022 legislative session, the General Assembly established legislative intent that a minimum of $3 million would be available annually for substance misuse prevention. So you'll see on the next slide, this base appropriation is paired with a one-time appropriation to collectively have the full $3 million available in 24.
For FY '25. Yes, sir. Go ahead.
So as the tax receipts increase in cannabis, you need the extra general fund to get to the 3 million. Is that what I'm reading?
That's right.
Okay. Okay.
Just trues us out back to that.
Yeah. Okay. Thank you.
It's just that bridge.
Right. Well,
Yeah, I don't
I guess I would use the word not as, but if the tax receipts. But
that's fine.
Representative Tolan, the representative.
I'm hoping it doesn't. So we need this. So fine. That's me.
If I may, another question I had, coming back to opiate use treatment. I've had a constituent in particular raise this issue where they've implied, offered employment to people who have substance use disorder. And occasionally those employees need to be able to take advantage of that hub and spoke model on a, it's hard to predict when those crises occur, or those needs occur. And the businesses want to be supportive, and yet are feeling the crunch in terms of being able to continue to support that type of employee. What kind of services or support do we provide here? Maybe it's not in this budget, but to provide the actual businesses that are, doing their part. It's been fabulous, doing their part to support our workforce, and including people with substance use disorder, so that we are not we're creating the right incentive for businesses to help in terms of providing that part of the solution.
that's where we've dedicated monies that go to the recovery centers to actually work on employment for the people attending those centers. There have been a lot of programming for employers in general about reducing stigma so that they invite this workforce as opposed to push away and create barriers. And there's a lot of anti-stigma campaigns that the health department actually funds. With this in mind, but also with people just getting into treatment and with youth and stigma that might be associated with them for some of their habits. So I think across that continuum, is really where we're at. But one narrow dimension of what you said is really crisis management. Someone has a stable employee who's been faithfully attending what needed to attend, and then they have a crisis and relapse. And how does that get managed? I'm not sure we have a specific intervention for that. It would be similar to someone who gets sick at work for whatever illness and needs to be replaced on a temporary basis. So I don't know if we have a special program, but we can find out.
Yes, that would be helpful because you could see how it could play out where,
Oh, yeah.
and it may not be a crisis which requires residential,
Right.
having a residential.
But a period of stabilization.
But it may be just being able to go to a spoke area for the day or for treatment. The problem is that the business is relying on that employee for certain output and it makes it very difficult for that business itself to.
I hear you.
So anything you can provide in terms of better understanding.
Okay. And the slide that's in front of you is purely prevention focused. So that's really these regional coalitions that we're providing more of with the money that we've had for this fiscal year and have further plans for the following fiscal year.
I want to make sure that you've got time, sir, but that last slide is really.
Yes, it's
Can I just ask?
Oh, sure.
Is the money, I'm revealing my newness. The cannabis money goes into the general fund? It's not a special fund?
Yes, it comes to us as general.
Yes.
General fund, okay, thanks.
Right.
And that's true of all the cannabis money. It's general, it goes into the general fund.
We can talk with,
That's a whole different conversation.
This is the education and prevention portion.
Okay,
Right.
all right, thank you. Wait.
So on this last slide, we have the previously mentioned substance use prevention money, but then more importantly, because it's the newest item on the slide, the hub expansion pilot, which is part of a broader vision, if you will, that you're going to hear about across, you may have heard about even yesterday from the agency secretary. A vision that really tries to manage co-occurring disorders, which we consider substance use and mental health co-occurring at the same time, which is a very high percentage actually, as well as co-occurring substance use disorders. So by definition, and this is federal regulation, if you are attending a hub, you have an opioid use disorder that requires the hub. It may be on methadone, maybe on buprenorphine. Doesn't mean that you should have any other substance use disorders you have ignored because you're going to have the opioid use disorder managed. But in fact, often other co-occurring, whether it's stimulants, whether it's alcohol, are not being managed at the same level. Same for the mental health issues. So the goal of this hub expansion pilot is actually, as part of that effort, to make sure the hubs are equipped to handle all of the things I just mentioned. The bigger vision has to do with also, you may have heard yesterday, to deal with expansion of the blueprint for the primary care setting and its focus on these co-occurring disorders, focus on Dulce program, which is the pediatric office with an embedded family specialist in it, which is a very preventive kind of focus. That's a real package looking at the crisis in mental health and substance use and trying to address it in a much more expansive way than current funding streams and current practice have allowed.
I'm going to assume that this is in the B1100 section of the bill. This is in the language, yes. All right. Our time is up on that last slide. Thank you for your detailed and willingness to entertain all of our questions. We're going to excuse you. And as we said, your 311 Department of Health and Public Health is through Representative Dickinson, and substance use is through Representative Broomley. And we'll filter our questions through them so you don't get all of us, all of it.
Did what you had get answered in the one slide? So
Yeah, exactly. Yeah. You mind if we take 3 minutes to switch over? All right. All right.
Thank you very much.
We should go offline for a couple minutes.